In this presentation, I shall be talking to you about those complications which occur sometime late after the suprapubic catheterization has been done. In my earlier presentations, which are separate on this site, I have talked about intra-procedural complications, and I have also talked about early post-procedural complications. You may watch those videos and then you'll be better placed. I shall be talking here about how to diagnose these complications, how to manage these complications, and how to prevent these inadvertent happenings. The late post-procedural complications, by that I mean anything that happens after 2 days to a month later. The first complication that I want to talk to you about is balloon incrustation. How do you diagnose balloon incrustation? And actually what it means? This means that when the balloon is in the bladder lumen, the surface allows incrustation, surface allows crystals to deposit on this balloon surface and also on the tip of the catheter, like the way it is shown here. This happens if the suprapubic catheter is placed in for long duration, patient has forgotten it, or he cannot come to you because of distance issues, or he has nobody to accompany, so he could not come. In those patients where there is more phosphaturia, the incrustation incidence is greater, and the diagnosis can be made that when you want to remove the catheter, suprapubic catheter, either the removal gets failed, your balloon is not deflating properly, or even if the balloon has deflated properly, the balloon incrustation has led to a formation of a stone kind of thing and you cannot pull it out. So either your removal fails or your removal becomes painful because the encrusted balloon becomes rough, and as you pull that rough balloon, it hurts the patient. The failed removal, you are trying to remove the balloon, you are trying to remove the catheter, which has been there for, let's say, about 3 months or 4 months. So then what you should do to diagnose the problem? You should do a plain X-ray and an ultrasound to quantify the degree of incrustation. Is it a partial incrustation or is it the complete incrustation of a balloon like a cast? Or some patients even form big stones around the balloon. Now you can have in the picture to your left something like a balloon, something like an eggshell formation, eggshell incrustation. Or in some patients on the picture to your right, the CT scan, you can see a balloon in the center and you can see a big chunk of incrustation, almost like a stone, thick stone. So you would know this only by the imaging, right? Do an ultrasound. If you think there's an echogenic substance over the balloon, do a plain X-ray or do a CT, right? To know what is happening. See, you can have something like that. And there's a picture from internet. And if you can have something like this, you have to probably operate this patient and then only you can remove the entire catheter with the inflated balloon. The balloon incrustation, the other situation, that you could remove this catheter in a balloon, but it is terribly painful. And if that is the case, you must do a suprapubic cystoscopy, antegrade cystoscopy, to find out that you're not left behind the fragments of incrustation in the bladder lumen. Because if you leave them behind, they will turn into bladder stones subsequently. So you must do cystoscopy and must wash. What I mean is this was the balloon which got encrusted, you deflated and you pulled this catheter out and you found that the partial incrustations are there in the balloon. Be sure that many chips of balloon incrustation are lying in the bladder lumen and they will form the stone later on. The second complication that can sometimes happen, anytime in fact, this is called catheter tip migration. How do you diagnose that the catheter tip has migrated? The tip may migrate to prostatic urethra, and then patient will start complaining of strangury, or the tip may migrate into ureteric orifice, and in that case patient will start complaining of flank pain. The catheter tip migrating into urethra, this sometimes happens on its own, spontaneously it may happen. Patient was living with SPC, he was walking, doing his daily life activity, somehow something happened, on its own the tip migrated into prostatic urethra. But sometimes, in fact more often, the tip migration occurs by your action. And I'll tell you what I mean by this. The spontaneous tip migration is when there is a catheter of this size with a long tip, like an elephantine nose hanging in the bladder lumen, and when the bladder gets compressed from behind, this tip is moving forward, backward, right? And it is possible that this tip finds way in the prostatic urethra. This is spontaneous migration. When bladder collapses, the tip moves forward and it goes into prostatic urethra. And this is the example of a spontaneous tip migration. If you do a suprapubic cystogram, you will demonstrate the tip lying as low down as the bulbous urethra in the picture on the left and close to verumontanum in the picture on the right. Now these patients sometimes drain, but they drain inefficiently. The bladder remains full, bladder remains has some urine in it, so it's likely to get infected. The tip sometimes can migrate into ureteric orifice. If it is a long tip catheter like that, it can find entry into dilated ureter orifice, and the ureter will become obstructed and patient will develop hydroureteronephrosis. And this is the example of a spontaneous tip migration into the ureter. You can see here the tip of the catheter fully into about 1 centimeter inside the ureter. This migration into ureter can happen on its own for unknown reasons. The second thing is what I was calling you is catheter tip migration iatrogenically done. Suppose here is a situation which is a pre-placed suprapubic catheter. That's how the patient is before you, and now you have been asked to change his catheter, remove the old catheter and replace by new. Now when you remove this catheter and as you put the catheter in, see, as soon as you remove the catheter, this bladder is empty bladder, right? And in an empty collapsed bladder, this is the kind of scenario. You remove this catheter, the track is oblique, you put catheter, it walks into the prostatic urethra. Because you have removed the catheter from empty bladder and you have put the catheter in the empty bladder. In an empty bladder, there is less space and the direction of the bladder is such that you can put it into the prostatic urethra. This is what I mean by iatrogenic placement into prostatic urethra. This does not happen always, but this can happen. What can you do about this? You will have to relocate the tip under C-arm. But the key question is how you have to prevent it. How can you prevent this? The spontaneous migration can be prevented by, suture fixing the catheter properly, having a smaller balloon, having a smaller tip of catheter. And then if patient having spasms, those patients who have more spasms, every time they contract their bladder muscle around the balloon, they push the balloon towards the internal meatus. And they push the catheter tip towards the bladder meatus, because that is the way the direction of force goes. Okay. So if you treat the bladder spasms properly in time, you can prevent spontaneous migration. The iatrogenic migration can be prevented by taking one simple precaution. And this is that suppose this was the case of SPC who was sent to you for change. You do what? First you clamp the suprapubic catheter and let the bladder become full like that. When the bladder becomes full now you remove the SPC, and as soon as you remove the SPC, put the fingertip on the track. Don't let it well out. Don't let it empty. And now in this full bladder, now you put the fresh catheter. And as you put the fresh catheter, it drains urine, quickly inflate the balloon and tug to the entire abdominal wall. What I'm only saying you, don't remove the old SPC from an empty bladder and don't place SPC in the empty bladder. I'm saying remove the catheter when the bladder is full and put a fresh SPC in a full bladder. And by doing this only, you can prevent the iatrogenic migration into the prostatic urethra. The another complication is epididymoorchitis. And this is simple to diagnose, local swelling, pain and fever. And it requires management. Often it requires change of suprapubic catheter because catheter is the seat of the bacteria. The catheter is providing a platform on which bacteria multiply. You have to give culture specific antibiotics for 3 weeks, minimum 3 weeks, sometimes longer. And if the patient is having bladder spasms, you give them anticholinergic. You have to do for prevention good SPC care. Sometimes you can have recurrent pyelonephritis. And why this occurs? Because if somebody who is having SPC, the tip of the catheter keeps rubbing around the ureteric orifice and there occurs edema around the ureteric orifice, and we have seen that whenever you do cystogram MCU in these patients, you show reflux. So cause of reflux is edema around the ureteric orifice. Good number of patients show reflux with SPC in situ. Now if this patient is also having bladder spasms because of the balloon or because of tip irritation, then this, because of spasm, some urine refluxes back into the kidney and this urine is full of bacteria. So then there are chances of pyelonephritis in this patient. Like that, right? This is the MCU that you did. It shows reflux on one side and there is a suprapubic catheter in place. So this is the more prone for development of infection. In this patient, give anticholinergic to control bladder spasm. Change the SPC, smaller balloon, smaller tip, give culture specific antibiotics, and then you can be successful in managing it. And finally, you can have a complication of bladder stone formation. This happens, why? I told you, if you leave behind these particles, they become bigger in size and form multiple stones in the bladder. The diagnosis is simple. These stones lead to frequent catheter blockade. The phosphaturia becomes more in severity and sometimes you can have hematuria coming along. More important thing or more disastrous thing to happen is that these stones themselves migrate down into urethra. And see in this picture, proximal to stricture, there is a radiolucent filling defect. This filling defect is caused by stone fragments which down migrated into urethra. And you do ultrasound of bladder, you find normal. You can only diagnose these fragments in urethra by plain X-ray or by MCU like that. You can have, in a rare situation, a complication called catheter tip erosion. In a catheter tip erosion, what actually happens is, if the one catheter lies at one particular location for a long period of time, the tip rubs against the mucosa. Mucosa becomes hyperproliferated, polypoidal, friable, inflamed, and sometimes the tip can erode and can cause hematuria, and patient can bleed per urethra like this, or sometimes have hematuria. So I have actually seen a patient of bladder perforation by insidious chronic tip erosion. So this can happen and you will have to manage these patients. I hope you have understood about these complications. In case you have any more questions, you can post to my email. I'll be happy to answer them. And till then, thank you very much for watching this presentation.